Now, obstetricians and gynecologists don't always get hung up on anteverted position, retroverted position, because uteruses can actually be flipped back and forth. Let me show you an example here. This is a patient with a small calcification in the anterior wall. A few seconds later, the uterus flips into a retroverted position here, and now we can prove to ourselves, yes, that is the anterior wall of the uterus. And you can sometimes do this with the probe by changing position. Here the probe is in the anterior fornix. Here the probe is in the posterior fornix. And you can sometimes have this uterus flip positions within a matter of minutes. The important thing is to understand where that anterior or posterior wall is so that you can place masses correctly or fibroids and not confuse the surgeon. You should know the blind spots in the pelvis. The blind spots are far above the fundus of the uterus, far lateral on the pelvic sidewalls, deep in the cul-de-sac, or very far anterior. You should be persistent about finding ovaries. Here's a fibroid uterus. You look quickly transabdominally. You see that the uterus is big. You don't see any other masses. You look transvaginally, and you realize that you can't see most of the uterus, but you use this opportunity to look for ovaries. You find an ovary beautifully, but you can't find the other one, so you have to go back transabdominally. Go back transabdominally and look high along the iliac borders to see the ovary. This is a complete evaluation. You don't just stop and say, I can't see anything, I can't see ovaries. You make an effort to find them. Maneuver the probe. Push with the probe. Check mobility of the mass. Separate masses. Elicit pain. Change position of the uterus to improve imaging. Use your non-scanning hand to palpate a mass or pull down on the ovary. Pull it down towards the pelvis. Create a wave. See if things move. Twist and turn the probe to try to unravel tubular masses. Here's looks like an ovary, but the patient had a question of an ectopic, and we saw something that possibly could be an ectopic, but could this be a corpus luteum in the ovary? We would push with the probe, and we try to separate them, and it turned out that the ovary rolled that way, and the ectopic moved this way, so that they were actually separate structures and not connected. Here's a mass. We want to prove that it is stuck to the uterus or not, so we push on it, and when the mass moves, the uterus moves. At no time were they moving in separate directions. We can change position of the uterus by pushing around. Here, this uterus looks like it's kind of parallel with the beam, and we know that's not optimal for sonography. So we push the probe into the posterior fornix and push that uterus a little bit, and now it flips back posteriorly into a retroverted type position, which makes it more perpendicular to the beam, which is good for sonography, good for B scanning, and we get much better detail about the uterus. Another example, uterus looks kind of clumpy, kind of parallel to the beam, can't resolve even endometrium. We push the probe into the anterior fornix, and that brings us closer, puts the uterus more in a perpendicular orientation, and we can actually measure the endometrium and see things much better. Maneuver your probe, twist and turn. Don't mistake a tubal mass for a septated ovarian mass. Try to unravel septated masses. Make sure they're not tubes that are folded over on themselves. In this case, it looked like there was a cystic adnexal mass, but when we turned the probe around, we saw that this was opening up into a dilated, fluid-filled tubular structure, a hydrosalpinx. Again, a mass that looks like a septated ovarian mass. But when we move the probe around, twist and turn, we unravel this mass, and we realize that it's a hydrosalpinx. and not an ovarian mass at all. Another thing to avoid pitfalls is use Doppler. Use it liberally. It'll help you avoid pseudo ovaries, helps you find true tubular structures versus vessels, helps you work out unusual cystic masses or unusual uterine masses, confirm color Doppler. Well, you have to confirm color Doppler. It's a spectral tracing. That's one way to avoid pitfalls. And with torsion and ring of fires, I want to make a couple comments. Here's something that looks kind of like an ovary. You turn on your Doppler, it isn't. It's just a cross-section of the para-uterine vessels. We make up ovaries all the time, so we have to be careful with this. What's happening here is we're slicing through some of these vessels that are coming in to the uterus, so we don't want to make that mistake. Here's another way of avoiding pseudo-ovaries. It looks like an ovary filled with follicles. But when you turn on it and work it out, you realize these are just Nabothean cysts in the uterine cervix. Use Doppler for tubular structures. This looks like a hydrosalpinx. Turn on color. Oops, it's just a vessel, a vein. This one looks like a hydrosalpinx. Nope, it is filled with blood flow, and that's just a prominent vessel. How about this one, where there's a postmenopausal lady that has a, quote, cystic mass, but there's something not quite right about this cystic mass. Where's the through transmission? Well, it's certainly as anechoic as the bladder, but we don't have good through transmission. When something doesn't look right, turn on the Doppler. And this happens to be an iliac artery aneurysm. Not exactly a job for a gynecologic surgeon to handle. Unusual areas in the uterus that are puzzling to us, turn on the Doppler. In this case, there was myometrial inhomogeneity and had some little irregular cystic areas. We turn on the Doppler, and it's high flow with low resistance. Turns out to be an arteriovenous fistula. Could be an arteriovenous malformation. It was composed of tortuous, tubular, cystic structures that had an unusual pattern. Again, this is not something that would be surgical. Now, when we do Doppler, please keep in mind that any findings with color Doppler have to be confirmed with a spectral tracing because color Doppler ultrasound signals may show artifactual flow. Here's a mass, looks like it has some blood flow in it. But when we do a spectral tracing, we cannot really get a good arterial or venous signal because these are flash artifacts. At the periphery of the mass, yes, we do have arterial blood flow, but there was really no true flow inside the mass. Here's another case where there was a pelvic mass that had it seemed some blood flow. This is a power Doppler. Well, we do a spectral tracing, and we see for sure there is arterial flow, and this now is a solid mass, adnexal mass, which turned out to be a tumor deposit in the pelvis.